Hi, this is Kathy Kennett from PPMD, and I'm happy to happy to see all of you registered and participating in our event today, Engaging Families in Care and Guideline Development. Before we get started, I just want to remind everybody that your lines are muted and that if you have questions, if you can write those into the lower left-hand box on your screen, we'll be sure to answer those when either at the end of the show or at the end of the presentation, or as appropriate when we during the webinar. We are joined today, or happy to be joined today, by Dmitry Kodyakov, who is a senior behavioral social scientist with RAND. His research focuses on methods of expert elicitation, patient and stakeholder engagement, and intervention and program evaluation. He's currently leading a project that develops an online approach to engaging patients and caregivers in clinical guideline development. We're also very happy to be joined by Brian Dinger, who's the father of two sons with Duchenne, Patrick and Matthew, and he became involved with PPMD, helping families locate and advocate for special education services and health benefit programs. Brian's also participated in the CDC-supported muscular dystrophy activities and has served as a public member for muscular dystrophy committees at the National Institutes of Health. At this time, I'll turn it over to Dmitry.
Thank you very much, Kathy, and welcome, everyone. Thank you for joining us today or watching us on YouTube later on. Brian and I are happy that you joined us, and we're happy to share the results of our study that is funded by Patient-Centered Outcome Research Institute, or PPORI, and the whole project is designed to develop a new method for engaging patients and caregivers in guideline development. So thank you very much for joining us today. So as many of you know, the care considerations, which are Duchenne care guidelines, have been recently updated, and the updated version was published in the journal called Lancet Neurology. And the guidelines have originally been published in 2010, and their development and updating have been spearheaded by the U.S. Centers for Disease Control and Prevention. The updated versions of the guidelines that were published earlier this year included new clinical evidence. It also included a renewed focus on patient quality of life, and it also included new sections of guidelines, such as on endocrine care, that have been not included in the original guidelines that were published in 2010. Although the renewed focus on patient quality of life was at the heart of the updated version of the guidelines, the group that developed guidelines didn't directly include families and patients and caregivers in the process of developing those guidelines. So what we wanted to know is, how can we develop a way to engage families in the process of guideline development? So, as you may know, during the guideline development process, what clinicians and researchers focus on primarily is research and clinical evidence, but they're increasingly seeking what's known as patient-generated evidence. And the reason why they're doing it is the guideline will affect the lives of the patients and their caregivers the most. So their input is very valuable and important to solicit in the process of developing guidelines. As you see on the slide, we say that patients and caregivers are best assessors of whether recommendation is patient-centered. So this idea of patient-centeredness, which lies at the heart of everything that Patient-Centered Outcomes Research Institute is doing, we wanted to operationalize it and implement it and use it as this concept in the process of developing guidelines. And we wanted to develop a method that helps solicit the input of families in the guideline development process through this notion of patient-centeredness. So as I mentioned earlier, there is an increased emphasis on engaging patients in guideline development, but it is oftentimes not clear who should represent the patient voice in that process. Oftentimes, guideline developers include 1 or 2 patients on the group that develops the guideline. But is it enough to have the input from 1 or 2 patients or caregivers? And who those representing patient voice should be? Should this be actual individuals living with a condition, or should be an advocacy group that represents their interests? It is a hot topic of debate in the literature. Also, engagement of patients with rare diseases may be particularly challenging, not only because it's a rare disease, there aren't that many, but oftentimes the participation, what's required to participate in the guideline development is extremely time-consuming and burdensome, because what patients are asked to do, they're asked to join clinicians and researchers in assessing the evidence behind the recommendation and pretty much serve similar functions as the clinicians and researchers would serve. Also, there is no consensus on how patients and caregivers can best participate. Should they be just consulted on what their preferences might be? Should they be joining the group that actually writes the recommendation? Or should they just evaluate the recommendations once they have been developed? Or should they be working on just preparing a family or translating the clinical recommendations into the language that a layperson could understand? So there are all those debates in the literature as to how best to engage patients and caregivers in the guideline development process. So what we decided to do, we decided to develop a new method that could be scalable, meaning that a much larger group of individuals could participate, or family members could participate. We also wanted the method to maximize participants' unique expertise. We didn't want the individuals with Duchenne or their caregivers become clinicians or researchers who evaluate what the evidence is telling them, or join the group that does an evidence review behind different treatment options. We wanted just to make sure that their input is valuable and they're providing input on what they know best. We also wanted the method to be consistent with how clinicians are engaged in the guideline development, to reflect the processes that clinicians used to develop the guideline. As I mentioned earlier, we wanted to accommodate large and diverse groups. So we wanted to include both individuals with Duchenne as well as their family members or caregivers. We realized that engagement could be burdensome, and we wanted to make sure that our approach is very convenient and non-burdensome to families, in that it doesn't require travel to a centralized location for an in-person meeting, or that participants could join at the time that's convenient to them. In the end of the day, we wanted the method to be applicable to other clinical conditions as well. So our approach hopefully will be useful to individuals for other clinical conditions as well. Instead of reinventing the wheel, we tried to work off of the already existing methodologies used to develop guidelines. One of the methods that we're employing here is Delphi method. And the Delphi method, for some of you who might not be familiar with it, is essentially an iterative approach to collecting the data, providing interim results back to participants, and asking them to reconsider their original responses. So you can think of the Delphi method as multiple rounds of a survey, where after a first round of a survey, you show the results to participants so that they see how their response compares to that of others, and then you're asking them to revise their original answers in light of group feedback. So that's the one feature that we try to retain or use in our approach, is this notion of iteration and feedback to participants. The second method that we're using is the Range-UCLA appropriateness method. This is the method that the CDC group that developed care considerations used to develop their recommendations. From this method, we use the 9-point rating scales that clinicians used, and they use the appropriateness they measured whether recommendation is appropriate and whether it is necessary, but we're using just the 9-point scale, and I will later on tell you what kinds of scales we've used in our approach. And we also use the analytic procedures for determining consensus. So pretty much the rating process that clinicians went to, we're replicating the process of developing those recommendations with in our method. And finally, we're using the features of the grade method, which is another method that Guideline developers use, but that has not been used in developing care considerations. And from this grade methodology, we are really focusing on how we can assess the replicability of panel findings. If one panel recommends something, would the other one recommend it? What we call consistency in their determinations. So these are the three methods, Delphi, Range UCLA appropriateness method, and grade method, that provide methodological basis for our approach that we've developed. So in addition to be based on these three methods, we also use the existing platform that is called ExpertLens. That's the platform that you can use to conduct online data collection using the Delphi method. So it's an iterative, online platform that allows you to collect input in an iterative fashion. So a typical ExpertLens process goes through 4 rounds, and this is exactly what we've done. So round 0, or what we call the idea generation round, is the round where you can ask open-ended questions that allows participants to share their ideas about the study topic in an unstructured manner. Then in round 1, or assessment round, you can ask questions and have participants answer them, and not only give you a numeric response to a question, but also allow you to explain their position. In the feedback and discussion round, or round 2, participants see how their response compares to that of the other participants' responses, and they participate in an online discussion. The discussion is asynchronous, meaning that you can contribute to the discussion at the time that's convenient to you while that particular round is open. It has a threaded structure, so there are different discussion threads that you can contribute. It's anonymous, so people do not know who you are, but they know a little bit about you. They, whatever the study organizers decide to reveal about you, such as whether you are an individual with Duchenne in our case, or a caregiver or family member, but not fully knowing who you are. And then finally, in the final round, the third round is the reassessment round. So you're revising the original responses based on the group feedback and discussion. So that's the iterative approach that we've used in this study. So let me tell you a little bit more about what happened in different rounds of the study. So in the round 0, or the idea generation round, we solicited input from 31 participants, 6 individuals with Duchenne, 23 parents, and 2 caregivers, where we asked them open-ended questions about such things as what makes care patient-centered. We also asked them to suggest and then rank order reasons for seeking endocrine care, because the endocrine care is the section of the care considerations that was new for the updated version of the care guidelines. And we've looked at 4 aspects of endocrine care: delayed vertical growth, weight management, bone health, and delayed puberty. We also asked participants to suggest and rank things that make it easier or more difficult to seek endocrine care. So that's our way of getting at barriers and facilitators of seeking care. And then we also asked participants to watch brief videos about the ExpertLens process so that they could provide input on ways to help us refine the data collection approach. So, and the results from this idea generation round helped us operationalize patient-centeredness of care guidelines, of the concept of patient-centeredness, and also describe patient and caregivers' preferences, needs, and values when it comes to endocrine care. And so that we shared the results of the idea generation round was shared with participants in subsequent rounds. So then in the actual panel, was conducted using a 3-round approach. So we've invited 122 individuals with Duchenne and their caregivers, and we randomized them into 2 panels. We really wanted to make sure that the results are replicable. So it's not just a random number that a small number of participants come up with, but something that we can replicate in more than one panel. So out of 122 individuals with Duchenne and their caregivers who were invited to participate, 95 of them, or 78%, participated in at least one of the 3 rounds of our study. So out of those 95 people, 54 or 57% participated in all 3 rounds, and 15 people, or 16%, participated in any 2 rounds, and 26 or 27% participated in only 1 round. So overall, 57% out of those who were participants in our studies completed all 3 rounds of the study. So what did we ask participants to do? So as part of this method that we are developing, they've rated and commented on the patient-centeredness of 19 endocrine care recommendations that were included in Duchenne care considerations. So then we've used their responses, their ratings, and determined whether or not the group agreed with each other, each panel separately. And we've calculated those group decisions using the Range-UCLA appropriateness approach to determining consensus. So that approach is the second methodology that informed our approach to patient engagement and guideline development. We also looked at the qualitative comments that people made in addition to their numeric answers, and I'll show you exactly what participants saw, and we analyzed those schematically. And because this is a study, we've also tried to evaluate our approach, and we asked participants to share their experiences with the online method by participating in the survey that was fielded after the 1st and 3rd rounds of the study. And then we've also interviewed a sample of 25 participants after the study was over about their experiences, and we'll share those results with you as well. So pretty much all of you are interested in knowing what does patient-centeredness means in the context of care guidelines and how we went about measuring it. So we define patient-centeredness as the extent to which a guideline recommendation accounts for patient care preferences, needs, and values. And we used 2 different criteria to measure patient-centeredness. So the first criterion is importance. So importance gets at the consistency of a clinical reason for giving a recommendation with the preferences, needs, and values of Duchenne families in general. So is the clinical reason why a particular recommendation is made consistent with your needs, preferences, and values? That's the importance criterion. And the second criterion is acceptability. So and that gets at the extent to which the process of following a given recommendation is consistent with the available resources and ethical standards of Duchenne families in general. So how burdensome the process of following recommendation, what the recommendation is telling you to do, how is that, to what extent it's burdensome to families. So then, let me show you exactly what participants saw. And some of you, I hope, have participated in the study who are on this call right now, and so this will not be new, but some of you may not have participated. So let me show you exactly what happened in round 1. So when participants logged into round 1, we presented them with 19 recommendations that were grouped into 4 different sections. And we'll show you exactly what sections there were and how the recommendations might have looked. And so here's one example. So we briefly summarized what the recommendation is telling you to do. We also provided a brief description of the clinical reason. So what is that recommendation trying to do? And what the process of following recommendation would entail. And then we also provided some additional information that we felt might be useful to provide your ratings of importance and acceptability of this recommendation. And so in addition of asking to provide a number from 1 to 9, where 1 is not very important and 9 is very important, we asked participants to explain their rating and identify factors that affected their responses the most. We did the same thing with acceptability of recommendation. So that's what happened in the assessment round. So a brief summary of the recommendation, explanation, what the clinical reason behind it was, and what the process would entail, and any additional information. All of this was written in a way that participants could understand, so we pilot tested this whole process before we ran the panel. So in the feedback and discussion round, we did two things. We summarized participants' ratings for each question. So you will see how many people chose each response category, how many people chose 1, 2, and so forth. We also show the red dot, which is how you answered this particular question. We show this blue bar, which tells you what the median response is. And if you hover anything on this chart, it would give you a plain English explanation as to what that means. At the bottom of the chart, we showed participants a decision, meaning whether the group, their panelists, considered a given recommendation to be important or not, whether they agreed with each other and what they agreed on. We also color-coded that decision. So if participants felt that this recommendation was important, the decision would have been in green font. If they didn't think it was important, it would have been in the red font. And if there were somewhere in the middle here of the response scale, the decision would have been presented in blue. So for those participants who might not be statistically inclined, they could just have looked at this decision at the bottom of the chart. Let's see. In addition to showing the statistical distribution, we also looked at the comments that people were making and grouped them based on their numeric responses. So we first analyzed the reasons for low ratings, such as ratings 1, 2, and 3, then the reasons for what we call uncertain ratings, 4, 5, and 6, and the reasons for high ratings, 7, 8, and 9. And we summarized those comments and said whether the comment was particularly relevant for patients or individuals with Duchenne or their caregivers, or it might have been a theme that was present in the comments made by both. So that was in round 2. And then participants participated in a discussion, in a threaded discussion of what was happening in round 1, in round 2. And so finally, in the final round, the reassessment round, we pretty much showed you what you saw in round 2 and asked participants to revise their original responses here if they felt the revision might be beneficial. So that's about the process of data collection. Let me briefly explain how we analyze the data. So we first looked at the responses to each question within one panel at a time. So there, as I mentioned, we have 2 panels, panel A and panel B. And so we first looked at what each panel separately determined. So that's what we call determination of patient-centeredness. So we looked at whether recommendation is considered important and acceptable by a given panel. And it was considered important and acceptable if the median rating was between 6.5 and 9, and there was no disagreement among participants. And then we looked at the certainty of patient-centeredness determinations. This is when we looked at the results across the panels. So panel A and panel B together. And we were more likely to be certain that a recommendation is patient-centered if it was considered important and acceptable in both panels. We were less certain about the patient-centeredness of a given recommendation if it was important and acceptable in one, but not both panels. And we were even less certain about the patient-centeredness of a given recommendation if it was uncertain importance or uncertain acceptability in one or both panels. This is not to say that if something didn't meet the criteria, our criteria of patient-centeredness, we would say, no, it's not patient-centered. What that means is that this recommendation is likely to be sensitive to a patient preferences, values, and needs. And this is something that we want to make sure that you understand is all of the recommendations that were used in this study have already been determined by clinicians to be clinically appropriate and necessary. So here we are trying to solicit input from individuals with Duchenne and their caregivers as to what they think about their patient-centeredness. And this is not to say that if something didn't meet the criteria of patient-centeredness, this recommendation should not be followed. Instead, it means that this is something that Duchenne families should be discussing with their clinicians and studying the reasons why some families didn't feel that it meant that it was not either important or acceptable. So let's see. Here's the results of our studies that combine the results from both Panel A and Panel B. And Brian, would you like to take over the next couple of slides?
Sure. So before I jump to the next slide, a couple of points I'd like to emphasize, and it relates to how the individuals who participated rated the various recommendations. If one thinks about how the care considerations were originally adopted, they brought together a group of people who were considered experts in Duchenne muscular dystrophy, and there were two different criteria for the selection of the recommendations. It was either evidence-based or based on expert opinion. And of course, evidence-based is considered more of a stronger standard, but in a rare disorder or in a condition where there is still uncertainty about treatment protocol, there may be individuals, medical professionals who treat individuals more routinely, and their expert opinion is used to make a determination whether or not there will be a recommendation for a particular treatment protocol. Similarly, when this group were looking at those recommendations, we used the criteria of important and acceptable, and I think that they are married together. It was not a determination of whether or not the participants believed that these should be or should not be part of the care considerations. It was whether or not there was reason for families to discuss this further with their Duchenne clinician to ensure that they were comfortable with the treatment protocol. Was it right for their family? So these criteria were chosen, and I think that says a lot about the way these care considerations were first developed. And then this particular project is looking at assessing whether these criteria, whether it will be in initial development, which is the plan to do this going forward, or when you're looking retrospectively at a set of resources, whether or not families and individuals who are intimately affected by a particular condition agree that these recommendations meet those criteria. So, as Dimitri said, we looked at a number of different recommendations. We brought together individuals who were directly affected by Duchenne, their families, and caregivers, and we tried to delve even more deeply than the typical group of panelists who often will participate in this type of an exercise, to get individuals and family members across the range of ages, so we would be able to make a determination as to how the community more broadly sees these recommendations and whether or not they felt that these were patient-centered. So we'll look at the first set of recommendations that were deemed patient-centered. And if you take a look at each of the individual points, delayed growth, weight management, bone health, and puberty, and we look at the areas of recommendations, we can see that they're fairly benign in terms of their use. Height should be assessed every 6 months from diagnosis through puberty. Impaired growth, bone age should be identified by X-rays. An endocrinologist should identify and address growth delays. These seem to be fairly benign in their recommendation. And the panelists, while there may have been discussion about the importance of some other topic that may have been higher for them, they agreed almost uniformly that these were patient-centered. One point to make about the delayed growth topic is the panelists look at the assessment of bone age by X-ray. We looked at it we broke it down into three age groups. We looked at the under 7 years of age, 8 to 12, and then 13 and older. And in the first two subsets of the original recommendation, the recommendation was considered patient-centered. Weight management, again, very common recommendations. Nutritionists should evaluate the diet and emphasize family meals, and should work together with the families on a nutritional plan. And physical therapists should emphasize family-focused activities. An interesting aside to those recommendations were some of the conversations that participants were sharing with one another. Was the concept of having a more direct involvement of a nutritionist to help them to plan these meals so that they were better guided. While the overall topic was deemed important, it was interesting that panelists were looking for more. They were asking for more, and they wanted the guidance. The same thing with physical exercise. The idea or the activity of swimming was uniformly mentioned across both panels as being very important, and families and individuals made a point of emphasizing the fact that this was something that they truly wanted to know more about. Looking at bone health, the baseline and intermittent X-rays to be done for all boys to establish a baseline was considered important. Again, intermittent long bone imaging for osteoporosis risk, and the use of IV bisphosphonates to be considered after low trauma bone fractures and compression fractures, or a moderate or severe Gannett score were uniformly seen as patient-centered. One topic that elicited much discussion was that of the recommendations under puberty. Families and individuals believe that endocrinologist referral with identified pubertal delays was, especially over age 14, was important, and that a graduated testosterone therapy be performed to mimic the typical pubertal development was another recommendation that the panelists all thought were patient-centered. So in the area where there was less certainty about patient-centeredness was in the area of delayed growth, and there was discussion among the the individuals about the use of human growth hormone. And I think that most of you can probably agree that when you start going into this area where there's a discussion of a treatment that's less common, that people are a little less comfortable with, they're going to have some of this concern, and that's where we started seeing some of this diminished certainty about the recommendations. Again, as I mentioned in the previous slide, we had broken the assessment of bone age for individuals into 3 age groups, and the panelists were concerned about patients over age 13 and whether or not the timing had passed to identify impaired growth for these individuals. But they also believe that it was, despite the fact that that possibility existed, they also commented that it might be easier to get an individual a little bit older to participate or take part in these scans because it was less stressful for older boys. Some of the greatest conversation revolved in both panels concerning human growth hormone, and I think that should not be surprising. Some of the comments were related to the fact that the inclusive evidence is not convincing enough to warrant treatments, and but there were others who said it's important depending on how impaired the growth is and how the treatment would affect any future growth at this age. So both panels thought that using the human growth hormone to address growth delays is not important enough based on a number of thoughts that they had involving the expense, how time-consuming it is, the uncertainty of how the individual would be affected by injections, the potential for side effects, and that was one of the concepts that was discussed readily was the fact that there was a lack of evidence about the treatment effectiveness. We had other presentations, and one of the points that I had made is, and I think that a lot of families will probably see a correlation with this particular treatment protocol and the use of steroids. While most families probably will agree that the use of glucocorticoids does help in delaying the onset of muscle weakness and preserves ambulation for up to 2 to 3 years in individuals with Duchenne, there is always concern about the treatment because of the many side effects. And again, this amplifies the need for families when they do run into these situations where there is uncertainty to make sure that they are discussing their concerns with their treating clinician so that they are thoughtful in whether or not they will initiate or they will undertake a particular treatment protocol. So other areas where they were less certain about the patient-centeredness had to do with the recommendations about puberty. And again, this was a very uncomfortable topic for families, not necessarily because of the idea of puberty, but because of the treatment and the distinction between the importance and the acceptability of the protocols. So pubertal assessment should be done by Tanner staging every 6 months starting at age 9. So panel B deemed it to be of uncertain importance, suggesting that there was more important, that many of the panelists said that there were more important concerns than pubertal delay. And then testosterone replacement therapy should be used for those older than 14 years of age who have no signs of starting puberty and who have low testosterone levels. Again, panel B deemed it to be of uncertain acceptability, raising questions about the tolerability of the injections, mood swings, and family resistance to using drugs to induce pubertal development, as well as a recommendation for testosterone replacement therapy to be considered in any boy over age 12 treated with steroids. Again, panel B seemed more concerned about the uncertain importance, and again raising concerns about the side effects. And it was interesting because some of the panelists, whether it was an individual or a family member, may have expressed somewhat different points of view. An individual with Duchenne had stated that it seems of secondary importance unless there was a psychological risk, and this person said that they were aware of. And then a family member commented that while the doctor visit and obtaining insurance coverage would probably be easy, administration of the treatment might be cumbersome along with dealing with the side effects. So you had different schools of thoughts that were expressed either by a caregiver or parent and an individual who was living with Duchenne. So in terms of discussion, you had two topics, as I've been mentioning, that had the greatest amount of debate, and there were tensions between the importance and acceptability with growth and with puberty. Again, a family member commented that the human growth hormone therapy can be used, but it may not necessarily be absolutely necessary. And they wrote that I think that you would need to speak with your endocrinologist directly about the side effects, about what you can expect. And they commented on their own experience about their son was on the borderline of being growth hormone deficient, and he was told he could qualify, but after speaking with the endocrinologist and hearing there was no guarantee for growth, they elected to avoid the treatment. Another caregiver commented that most children with Duchenne are in a wheelchair full time, and at that point they may have had spinal fusion. So unless the impaired growth was significant and bothered the child, they didn't consider that at that point that there was was it not an issue that needed to be worried about. And again, differences between the caregivers and the individuals with Duchenne was regularly highlighted in their conversation, especially when it came to puberty. An individual with Duchenne said at the stage of while undergoing puberty, if there are growth issues, then I think that there could be fairly significant avenues that would need to be explored for treatment. So families and individuals, while they may have uniformly supported some of the first recommendations, the other recommendations, especially with growth, identifying growth delay and pubertal development, did elicit a little bit more conversation and a little bit more tension among the participants. And that was interesting. Another thing I would like to add is the fact that during these discussions, there were moderators who helped the participants either find information that was relevant to the discussion or tried to pose questions that would help facilitate further discussion. But every measure was taken to ensure that these questions were asked in such a way that they did not inflect bias and allowed the participants to express their own thoughts, and the conversation would have a more natural flow. So at this point, I don't know if there are questions that people have about the process or about some of the information that's been provided. I'll ask Kathy if there's anything that's pressing, and if not, we can turn back to Dimitri.
I don't see any questions, Brian. Again, to the audience, if you have questions that you'd like to ask Dimitri or Brian, if you can type them in the box in the left-hand corner of your screen, we'll be happy to address those. At this time, Dimitri, do you want to continue?
Sure. Sounds good. Thank you, Kathy. Thank you, Brian. Just wanted to mention that one of the things that was happening in the discussion around that Brian mentioned was that the participants could see whether a comment was made by an individual with Duchenne or a family member or a caregiver. And we've noted some of the differences between what individuals with Duchenne had in their minds versus what caregivers, what concerns they may have had about different recommendations as well. So at the end of the study, we asked participants to share their thoughts about the process. And the last portion of our presentation, I would like to focus on what participants had to say about the process. So as you see, the vast majority of them had positive things to say, that they were satisfied with our approach. So 68% said that they would like to use the Expert Lens tool in the future. 71 felt that the system was easy to use, so they agreed with that. 80% said participation in the study met their expectations. 83 felt that participation was satisfying, and 89 felt that they were able to express their views on the study topic using the Expert Lens platform. So through the qualitative interviews that we did with 25 participants in the end of our study, there are four overarching themes that emerged through the feedback that we've received. So one of the things that people enjoyed particularly about the online process was that it encouraged them to learn about the condition and the experiences of other people, and promoted community building. So we had participants from different parts of the country. Some of them were in the rural areas, and they have not had a chance to interact with other families directly. So they appreciated not only seeing how participants rated importance and acceptability, but also they enjoyed the discussion component of it a lot, because they felt that they have a better understanding as to why participants rated certain things in a certain way, and they felt that that helped them better understand the perspective of people who may have different positions than theirs. Others have, and family members in particular, like the fact that they could revise their responses at the end of the discussion based on the new information that they've learned. And they felt that the discussion helped them understand a lot more about the phases of the disease and what's really important and what's not important. So when we were assembling the panel, we tried to balance it in terms of the age of a child a caregiver is providing care to. So we tried to have participants who provide care to younger boys and to older boys. And then we also had individuals with Duchenne who were adults already, who have gone through all of these stages already. So learning from their experiences was really important for our study participants. The second feature of our approach that participants commented on was convenience, anonymity, and the synchronous nature of the engagement. So families are very busy. It's really hard to travel. So the fact that it was online, the fact that it was asynchronous, meaning that they could participate at any time that's convenient to them, even at night. So they appreciated that they could start and do a portion of it and then come back to it later was another aspect that participants liked. So anonymity was really important, but they also appreciated knowing whether a comment was made by a family member or an individual with Duchenne. So keeping those labels attached to comments was a good thing from the participant experiences. So discussion helped participants clarify issues, but it may not have influenced their ratings drastically. So as this quotation from an individual with Duchenne suggests, that the reasoning for his responses might have changed, but not the numeric answer. And some of the comments reinforced their original responses, their original experiences. So a similar comment from a family member. So while the numbers might not have changed, they have increased understanding of certain topics, in particular the growth hormone recommendations. And finally, the last thing that people commented about is the usefulness of our approach to bringing patient voice in guideline development. As we mentioned earlier, when clinicians develop the guidelines, they look at the research evidence and clinical evidence, and here's the way to provide patient-generated evidence that they felt would be useful for physicians as well as for families who may not have an experience with a particular recommendation, like a puberty recommendation, if you have a younger child who has yet to enter that stage. They also appreciated knowing that their voice counts in the guideline development process as well. And here's a comment from family members supporting the usefulness of the approach for clinicians and doctors, because that provides them with information that they may not have and helps them better understand what matters the most to families, so that acceptability and importance of recommendations are valuable variables in developing guidelines. To summarize, our method and it's where it might be useful. So we think that the method is useful for engaging large and diverse groups of patients and caregivers in the guideline development process, regardless of the clinical condition. So even though we've developed it and tested it with Duchenne families, we feel that the same approach could be used for other clinical conditions as well. We feel that the method is useful for promoting a dialogue between patients, caregivers, and providers, so that qualitative discussion between the two rating rounds and the reasons for the ratings could be useful information for families to review before making a decision or engaging in the shared decision-making process with a provider. It can also help facilitate community building among patients and caregivers, especially the ones who are located in remote areas. The online feature, the online nature of the process is useful for them in particular. Creating an informational resource about patient experiences, preferences, and needs is really important for guideline developers. So engaging patients and family members before the guideline recommendations are finalized is something that we hope would be happening more going forward. So with that, I would like to open for questions and comments.
Thank you, Dimitri, and thank you, Brian. Those were excellent presentations and answered a lot of questions in this area. And patient engagement is something, obviously, the PPMD is extremely engaged in and thinks is incredibly important. Dimitri, have you had interaction with other disease groups or advocacy organizations who might be interested in this process for their diagnosis or their population?
Yes, we gave a presentation at the Guideline International conference earlier this year that took place in the UK. And people, regardless of what areas or medical conditions they work on, were very interested because they felt that the process is not too burdensome, and it could be the rating criteria could be applied to other conditions. But at this point, we don't have any concrete plans of using it for a particular other condition just yet.
Thanks. There's a couple of questions, but well, one of the questions is whether there are statistics on Duchenne patients who are able to have a family, and as everyone on this call is, I'm sure, aware, we have thankfully a growing population of adults with Duchenne, and so that statistic, I'm sure, will continue to increase and be collected as as the years march on. So at this time, currently, I don't believe that there are statistics on patients who have Duchenne who are able to have a family. There's also a question about resources that are available by state. And Brian, do you maybe want to talk about the resources that are available on the PPMD site regarding state-by-state availability?
Yes, currently PPMD has populated a list of resources in the area of special education, disability rights advocacy organizations, and state benefit programs. There currently is not a list of qualified mental health therapists and physical therapists yet available by state. But I would imagine if you contacted the organization's professional societies, they probably could get that information to you. But that is not one of the areas yet which PPMD has added to that growing list of resources. In that particular list, again, discussing state benefit programs, there's a list of Medicaid waiver type programs based by state, as well as some of the Medicaid options, some of the home and community-based service waivers that are available through the lifespan of an individual that can be found. And if families do have information that's missing from those resources, please contact PPMD through the community site and send that information.
Thanks, Brian. And in addition, there are 22 now certified Duchenne care centers in 22 or in several different states. So if you are in a state that has a center and you're seen at that center, contacting the center about mental health needs and resources would be appropriate, and also social workers that are caring for patients at those centers can be helpful as well. Dimitri, are there plans to expand this effort to other systems, processes, for example, cardiac or pulmonary, any other processes in Duchenne that this might be appropriate for?
That would be great. So we only focus on endocrine section of the care considerations, but the method could be used for others, for other sections. So yes, if Guideline developers are interested, I'll be happy to, Rand will be happy to work on using the methods for any future revisions of care considerations or applying the method to other sections of the updated guidelines that have been published earlier this year.
Thanks. And also, I know that we have plans for dissemination. Could you talk just a bit about what those plans might be?
So, yes, so we have already given talk at the Guideline International Conference. There might be a webinar that's been so they were working on for that group as well. So we're drafting a manuscript that summarizes the substantive findings from this project that will be sent to an academic journal. Brian and I are also working on the more community-focused piece that would be shared in a more, how should I put it, less academic venue that focuses on patient engagement in general. But if conference attendees have any other ideas, we welcome their input on dissemination as well.
Thanks. And in addition, the care guidelines that were updated by the CDC are available on the PPMD website in their entirety, as well as in the family guide, as well as in updated imperatives of Duchenne MD, which is a one-page description of the care that's necessary, in most cases annually, for every patient with Duchenne. So if you have any questions, please feel free to contact one of us, and we'll be happy to get you the information that you need. I don't see any further questions. Dimitri, would you like to give any closing comments?
Well, so our contact information is on the last slide. We'll be happy to answer any questions that you may have, because sometimes people might be shy, and sending us an email to me or Brian might be the best way to reach out to us, and we'll be happy to answer any questions you may have. Brian?
The only final thought that I have is the significance of how the people who participated in this really enjoyed that the exercise, and how I think that this is somewhat related to the new phenomenon of social media as a way to learn about a condition with other families, and I think that's extraordinarily important. But it never diminishes the significance of making sure that you when you want to make a change in your treatment protocol, that you certainly include your medical professionals who will help you to understand whether or not a particular program is appropriate, or opting not to do one, how that may affect an individual or family. So while the online resources are certainly of great value, certainly the traditional engagement of medical professionals is still highly important.
Thanks, Brian, and thanks, Dimitri. Thanks to our audience. We truly appreciate your attendance and your participation. As with other PPMD webinars, this webinar has been recorded and will be available on the website for future viewing and attention. So thank you again. Thanks to our presenters, and this concludes this webinar.